All right, well, hi everyone. My name's Julia Dare. I'm the Director of Development with NAMI Mercer. I'm going to be moderating this webinar, so I just wanted to go over some really brief housekeeping. If you have questions, we're going to go over the Q&A at the end, so just pop them in the chat, and then Dr. Deibler will answer them at the end of the session. And then if you could stay on, there will be a brief survey that'll pop up after the webinar is over, and we do ask that you complete it. It'll really help us to find out if you found the webinar helpful, and it'll help us inform future Harvest of Hope workshops. So with all that being said, it's my pleasure to introduce Dr. Marla Deibler. She is a licensed clinical psychologist and executive director of the Center for Emotional Health of Greater Philadelphia, specializing in the treatment of anxiety disorders, OCD, and neurodevelopmental disorders. Dr. Deibler serves on the Scientific Advisory Board of the TLC Foundation for Body-Focused Repetitive Behaviors and on the faculty of TLC's Professional Training Institute. Her other positions include President of the Board of Directors of OCD NJ, Consultant for the NJ Center for Tourette Syndrome and Associated Disorders, and the Visiting Clinical Supervisor at the Rutgers University Psychological Services Clinic. Dr. Deibler holds a doctorate in clinical psychology and a postdoctoral Master of Science degree in clinical psychopharmacology, and today she's going to go over evidence-based approaches to understanding and treating obsessive-compulsive disorder.
Thank you so much for having me. I'm excited to be here today to talk a little bit about OCD and how OCD is treated. And we are just on the heels of OCD Awareness Week, so it's actually pretty apropos that we are talking about this today. So to get started, I wanted to talk a little bit about some common myths out there about OCD and how it's portrayed in the media. So for example, I'm sure everyone has heard the phrase, "He's so OCD," or "My OCD is acting up." And what people generally mean by that is that they have a preference for neatness, right? They like to be organized, and that this is a good thing, that this is an attribute. When in actuality, this is actually not OCD, and it's far from what OCD is like in terms of the experience of having OCD. Another time you might often hear the use of obsessive-compulsive disorder is when people refer to being obsessed. So she's obsessed with someone, or she's obsessed with something. And what they generally mean is that they have an affinity for that thing or an infatuation with that person. And it is used as a positive, pleasant experience. But OCD is far from that. OCD is not an adjective. It is a mental health disorder, and it's not at all pleasant. Having an obsession is not a pleasurable experience. Having an obsession is actually quite distressing, and it drives compulsive behaviors as a means to get rid of that obsessive thought. So OCD is a disorder that is very much unwanted. It's very much distressing, and it can really impair someone's functioning. I wanted to give people a sense of what OCD is like beyond just describing it. This is a really nice little clip a filmmaker made. This filmmaker has OCD and wanted to demonstrate for the viewers what OCD is like to live with. Oh, thanks.
Congressman Andy Kemp is delivering for New Jersey with a plan that will create thousands.
3, 4, 5, 6. How long did I sleep for? I got to bed at 3. Let's see, 3 o'clock. I didn't do anything stupid yesterday. 4, 5, 6, 7. How many hours did I sleep? How many hours did I sleep? How long did I sleep for? 3 a.m. 2, 3, 4, 5, 6, 7. I'm feeling lightheaded. My heart's a little lightheaded. Feeling lightheaded. I don't feel good. My heart's beating. I don't know if I feel all right. I think I feel all right. I'm okay. Yeah, I feel all right. No, I feel fine. I don't know if I should take my meds. I should take my meds. Should I take my meds today? The medicine's working. It's going to work. The medicine's working. I should stay on the medicine. How do I know if the medicine's working? I don't know. Should I take the meds today? How many hours did I sleep last night? I didn't get enough sleep. 2, 3. My pulse is slow. 4, 5, 6, 7, 8. It's fast. It's fast or too slow? 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 11. What happens when your pulse is too slow? 13, My appetite really isn't there. I hope it's okay. I don't really have an appetite. My appetite's not great right now. Why? I'm sick. You're not sick. You're fine. Maybe I'm too hungry. I shouldn't be this hungry. Oh God, I'm too hungry. It could be my thyroid. That's why I'm sick. It could be my heart. My heart is my thyroid. You know what? I'm gonna write. I'm gonna go write. 1, 2, 3. Looking forward to writing. 6, 7, 8, 9, 10, 11, 7, 13, 14, 15, 16, 17. I'm looking forward to writing today. I can't wait to write today. It's coming. It's flowing. I'm writing very well. I like this story. I'm gonna write a lot. I'm gonna write so much today. I'm loving this. It's great. My stomach's hurting. My stomach's really hurting right now. My stomach's really hurting right now. I hope it's not Ebola. I was on a plane recently. I hope it's not Ebola. Oh God, I need to look up the symptoms. Right now, it could be Ebola. Don't look up the symptoms. Don't look up the symptoms. I need to look up the symptoms. Do I have Ebola? What's going on? I need to take my temperature. First temperature. Fine. Okay, I can't tell if I'm hot or not. My fever. If it's over 100, that's not good. If it's over 100, I'm going to the emergency room. Okay. What's my pulse? I am checking my blood pressure right now. I think I'm fine. I think I'm sick. My blood pressure's high. My blood pressure feels high. My blood pressure feels really high. I'm freaking out. I'm freaking a cigarette. I'm gonna just have a smoke. I read cigarettes are good for your intestines, actually. Why am I smoking? I hope I don't get cancer. Why am I doing this? This is a heart attack. My heart is racing right now. My heart is racing. My heart is racing. Okay. This is an anxiety attack. This is a heart attack. I can't take a deep enough breath. I feel like I'm gonna pass out. I need to sit down. I need to go over here and sit down. I can't breathe. Smoking increases your heart. Wait, I gotta just sit down. Just wait. It kills you. Smoking is killing me. Why did I do this? This is ridiculous. Okay. Relax. You got this. Remember meditation. Remember the breath. Just focus on the breath. It's just anxiety. Nothing ever happens. It's just anxiety. You'll be fine. Nothing ever happens. It's just anxiety. Into the breath. You're okay. See, you're fine. See, you're okay. I hope I got enough sleep last night.
Excuse me for one moment while I reshare my window with everyone. For some reason, quit out of my slideshow. Okay. So as you can see, having OCD is really not a pleasant experience. So OCD is a disorder that is characterized by both obsessions and compulsions. Obsessions are any kind of recurrent, persistent thoughts, images, urges, impulses that are intrusive. They come into the mind and they're unwanted. They cause a great deal of distress, anxiety, disgust. And in response, attempts are made to ignore, suppress, or neutralize those mental intrusions because they're so distressing. So the mind tries very hard to try to make it feel better. And those attempts to make it feel better are called compulsions. Compulsions are repetitive behaviors or mental acts that are carried out in response to that obsession or in accordance with very rigid rules. So things have to be done a particular way, very specific way. And if they're not carried out in that way, then they need to be repeated until they're done properly. And the purpose of carrying out a compulsion, again, is aimed at reducing distress or preventing some kind of feared outcome from occurring that is related to the obsession. So this is essentially how OCD works and why it reinforces itself. And it's why it's so hard to break the cycle. So it begins with a trigger. For example, a thought that someone has to go walking through the door. So if you have to open a door, that could potentially be a trigger situation. Another thing might be an internal experience rather than an external experience like opening a door. An internal experience like experiencing a leg cramp could potentially serve as a trigger for someone's OCD. And what happens is that the mind misappraises that situation as being dangerous, and somebody experiences a frightening thought, essentially an obsession. For example, with the idea of someone having to walk through a door, they might think, if I grab this door handle, I could get sick from germs that are on the handle. And that causes a great deal of distress. If it's some internal experience like that leg cramp, when someone notices that they're experiencing that leg cramp, they may have then a thought come to mind that maybe they have a blood clot. And again, this causes a great deal of distress. So these obsessions, these intrusive thoughts, lead to a great deal of discomfort and internal distress. And we as humans don't like to feel that much anxiety or that much disgust or that much arousal in general. It's uncomfortable. And we are built to try to neutralize that, to make us return to our homeostasis and feel better. And so when we experience these obsessions, we experience a great deal of distress and arousal. And naturally, our minds want it to feel better. And so what we typically do in response naturally is to try to avoid or to cope in some way with some sort of compensatory behavior. And that is a compulsion. So the compulsion is carried out to neutralize the threat, to bring down the chance that a feared outcome will occur, or to reduce the stress that is associated with the obsession itself. So for example, with the idea of having to walk through a door and having the thought, if I touch this door handle, I could get very sick from germs, and experiencing a lot of anxiety. And as a result, one might say, okay, I need to wash my hands or use Purell after I touch the door handle so that I minimize the likelihood that I'm going to have germs on my hands that I could then get sick from or pass along germs to others. Or the example of a leg pain. If someone has that thought, maybe I have a blood clot and they're experiencing a whole lot of anxiety, they'll attempt to bring down that distress by, for example, doing an internet search and Googling leg pain. What could this be? And then internet searching, like you saw in that video, actually. And what happens when people engage in compulsions is they get that short-term temporary relief, and we are creatures of immediate reward, right? We just want to feel better when we are feeling really distressed. And so when someone engages in hand washing because they are feeling really distressed from the thought that they may get sick, they immediately feel better. Whew, thank goodness. And so that is very reinforcing. That's a learned experience that teaches us that next time we feel that anxious, when we have that thought that we could get sick, we're going to hand wash. And if we hand wash, that will bring down our distress. Unfortunately, two things happen. One is that it doesn't typically do the job after a while. So at first, perhaps it brings down the distress some, and it feels relieving. But the more this happens, the more these obsessions come up, the less and less effective those compulsions are at bringing down the distress. And so the compulsions grow because maybe it's not one pump of soap that's good enough. Perhaps there's still some germ on my hands. Maybe I need to have 3 pumps of soap. Maybe I need to wash for 5 minutes instead of 2 minutes. And so the compulsions can grow at this attempt to continually try to get rid of or make the distress feel better, and to minimize the risk or perceived risk associated with that obsession. The other thing that happens is that there's an absence of a corrective experience. So the person, if they are hand washing immediately, they don't get to learn that the likelihood of you getting sick from touching a doorknob is pretty low. And it's a risk that most people are willing to take. And so there's this absence of corrective experience. They don't really get to disconfirm that these worries are not likely to happen or that they're not true. And that reinforces their OCD. So there are a lot of different kinds of obsessions that people can have. These are the most common ones that we frequently see. There are obsessions related to contamination, right? Feeling dirty or covered with germs or contaminated in some way. Thoughts of physical illness or concerns for one's health, like the idea of perhaps getting cancer or some other serious illness, or feeling that any kind of ache or pain that one perceives might potentially be something very serious. Intrusive sexual thoughts, unwanted sexual thoughts like related to violence or related to anything else that might be considered taboo. We see this at various ages and can be particularly problematic for younger folks who also have the understanding that they may be too young to even be thinking about this kind of content. There is relationship OCD, wherein people doubt the relationships that they're in, that maybe this isn't the right person for them, maybe they aren't loved, maybe they don't really love this person, and it's quite distressing. There are magical thinking kinds of symptoms or superstitious symptoms, right? Like the idea that walking under a ladder brings bad luck, for example, this magical thinking kind of symptom wherein a thought becomes related to a behavior, but these things are not connected in any way. So that becomes quite problematic for folks. There's religiosity, which we also refer to as scrupulosity, right? Wherein people have concerns related to their religious beliefs. Like, for example, they fear that they may offend God, or they may utter blasphemous language, and concerned that perhaps they'll go to hell. There's moral scrupulosity, which is over concern for one's values, making sure that everything they do is of the utmost highest moral character in terms of the thoughts that they have and the behaviors that they carry out. There are perfectionistic kinds of obsessions where everyone who has this sort of symptom feels like things need to be perfect or just so, or needs to be to the best of one's ability to the extent that it is disabling. And then there is something that we call just right OCD, or sometimes we call Terretic OCD, because it's not necessarily linked to a feared outcome like a lot of these other kinds of common obsessions, but instead it is related to a bodily discomfort that something just doesn't feel right. So things need to be, for example, done over again. There's a lot of repetition, typically touching, tapping, arranging, these kinds of need to act because it just doesn't feel right. So this idea of it being right needs to feel just so is a common obsession as well. It's also called Tourettic OCD because it's not connected to that feared outcome and is sort of like a tic in nature, like Tourettic in nature, because it is a physiologically felt urge, essentially, that something needs to be discharged to feel better, like a tic. Some other commonly occurring obsessions that are often misunderstood, sexual orientation OCD, wherein people get stuck on the thought, how do I know I'm not gay if they're straight, or straight if they're gay? And the issue is not really whether or not they are. That's not the debate at all in their minds. The problem really is the idea of not being certain and never being certain. How do I know that I'm not? This obsession of what if I'm pregnant, or what if I could get pregnant in impossible circumstances. So we sometimes see people who won't use public restrooms because they're afraid that perhaps someone of the opposite sex sat on the toilet before them and they could potentially get pregnant from sitting on the toilet seat. And they typically have very good insight. They know that this is not possible, but their OCD tells them it is. And so they experience a great deal of distress nonetheless and engage in avoidance behaviors and other kinds of rituals to try to decrease the likelihood that that might happen in their minds and to decrease the distress associated with the thought. Also, an obsession that involves fear of losing control, and that typically manifests itself as How do I know I'm not going to hurt myself or kill myself? How do I know I won't hurt somebody else on purpose or kill somebody else on purpose? And again, these are really ego dystonic thoughts. That is the telltale sign that this is OCD and not real. So I cannot tell you how many times we see individuals who, for example, kids in a high school has the thought that maybe they'll lose control and hurt themselves. And they're really distressed by it because they're not depressed. They don't want to hurt themselves, but they have this thought that maybe they could potentially, unknowingly, unintentionally lose control and kill themselves. And so they go tell the school counselor and they say, I'm worried I'm going to hurt myself. And the school counselor then calls parents and says, you need to be evaluated, right? And so they wind up going to a higher level of mental health assessment, and it can become a real mess when in actuality there is no risk to them. They are not in any danger. The problem is that they're experiencing a great deal of anxiety related to a thought that they don't want to be having. We see this also in what we call perinatal OCD. Oftentimes, individuals who have OCD, or sometimes they'll have postpartum onset OCD, will have this intrusive thought that they may unintentionally harm their child. And that becomes really distressing to them. And then they engage in lots of rituals to try to minimize that perceived risk and to minimize the great deal of distress that they experience because of having the thought. And then there's a concept called loss of essence OCD, which manifests itself as the idea that if I'm around someone, I may take on characteristics of that person, or I may take on the characteristics of an object if I am near them. Sometimes we'll see that in individuals who maybe have a sick relative, and perhaps the relative is in the hospital, and it's nothing contagious that the person is sick with, but they fear that if they are around the person, that because this person is very sick, that they may get really sick in the same way. Sometimes we see kids who have this, sometimes have the thought that if I am around people who I perceive as, bad kids, or who are demonstrating behaviors that are not acceptable, that they are then going to take on those characteristics. They're going to become like them. And so that becomes very distressing, and it drives compulsive behaviors. So compulsions can come in all different shapes and forms. There are lots of different things that people do to try to decrease their distress. And these are just a short list of common compulsions. So for example, cleaning and washing and disinfecting for contamination, checking and reassurance seeking from other people, asking people, is this okay? Is this safe? Checking all sorts of information, confessing or the need to tell someone something, praying, doing things over, redoing, rewriting, repeating, touching, tapping, ordering, things needing to be symmetrical, counting, as you saw in the example video, and all sorts of avoidance behaviors and other kinds of safety behaviors, like needing to be around a safe person, for example. And more commonly misunderstood things, commonly misunderstood compulsions. So out there in the internet world, there's a concept that people refer to as pure O. And what they mean by that is purely obsessive. In other words, no compulsions, only obsessions, only the intrusive thoughts or images or urges. But in actuality, that's really a misnomer, because the compulsions in these cases are actually mental acts. They're not physical actions. So compulsions are there, but they're not observable to someone else. So whereas you might see somebody checking the locks on the door, or you might see someone engaging in hand washing, these are not observable like that. These are mental acts. People may do things like saying specific words in their minds or phrases in their minds, or praying, for example, imagining neutralizing images, positive images in their mind to make themselves feel less distress, counting in their minds, any kind of mental act or thought that brings down the anxiety, mental counting, mental list making, mental reviewing of things that have happened if part of their OCD doubts what has happened in the past. And so they mentally check what has happened by mentally reviewing events, trying to figure it out and think things through. There's a really never-ending amount of thought that can go into repetitive attempts to try to bring down one's distress. And so the relationship between obsessions and compulsions look like this. So for example, if someone has the obsessive fear of harm to oneself or to others, like they're going to potentially lose control and hurt someone or themselves, what they might do is to check or to seek reassurance from other people. They might say, I wouldn't do that sort of thing, right? I don't think I'm the kind of person that would do that sort of thing. They might ask someone if something is safe, or if they would ever think that they would be harmful to someone. That need for that just right feeling, that obsession, that urge, oftentimes people will engage in repetitive movements like touching, tapping, repeating of things like locking the door over and over and over until it feels just right, or until they hear it click just so that they know that it's locked. So their mind says, okay, it's safe, it's locked. An intrusive, unwanted, violent thought or violent image. Someone may engage in some sort of neutralizing imagination. So they might imagine some positive image, like a field of flowers, or they might imagine a phrase like, I would never do such a thing, or it's safe, it's okay. And so the obsession is what causes the distress. The compulsion is what is carried out in order to decrease the distress. And OCD is quite common. It occurs in about 1% to 2% of the population. It is equally prevalent in males versus females, so it does not discriminate in gender. It also doesn't discriminate in ethnicity, nationality. It is equally distributed amongst a lot of different kinds of groups. Although it is equally prevalent in males versus females, the onset is a little bit different in males versus females. About 50% of those with OCD do report a childhood, adolescent age onset, typically late childhood, early adolescence. But males tend to actually onset with symptoms earlier than females. And so in our offices, for example, we see younger boys much more frequently than we see younger girls. And we also see earlier onset in boys that have a family history of OCD or anxiety disorders or tic disorders like Tourette's. That onset that happens is typically gradual. This is not something that happens overnight. This is something that typically starts off very small and grows. However, there is an exception to that. The exception is a phenomenon called PANDAS, or Pediatric Autoimmune Neuropsychiatric Disorder associated with streptococcal infection. It is also referred to as PANS sometimes, which is Pediatric Autoimmune Neuropsychiatric Syndrome. And essentially what that is it's the body's immune system over-responding to a viral infection or a bacterial infection. And what happens is there is inflammation as a result, a neurological inflammation. And that creates a very sudden onset of OCD symptoms, along with other symptoms as well. And it typically doesn't abate until that infection is treated. So for example, antibiotics are a common treatment at that point. They also need to usually be treated other ways as well. And they're typically more likely to have recurrent infections. So this is really a a problem that needs ongoing treatment, and it's typically multimodal. They do therapy and medications and prophylactic antibiotics, and it's quite a challenge for families that have PANDAS or PANS. But onset of OCD is typically gradual. It starts off small. Individuals try to keep it under control by engaging in their compulsions to keep their distress low, but that unintentionally reinforces the anxiety, and it grows and generalizes to other things. The course of OCD is typically waxing and waning. So this is a condition that ebbs and flows over time in response to a lot of different things in life, including just life stressors and events. And OCD, although it can certainly occur in itself, it often co-occurs with other kinds of anxiety disorders. So it's not uncommon to see someone who has OCD and maybe also generalized anxiety disorder, for example. So where does this come from? As with most psychiatric disorders, it's complicated. Usually has multiple factors involved in terms of why they're experiencing this phenomenon. There is a genetic relationship. Research does indicate that OCD is highly heritable, and it is likely to involve multiple genes. So there's not one single gene involved. We do believe that it is multiple genes involved. And there are numerous OCD genetic studies that are trying to parse out what exactly that looks like and what we might be able to do about it if we can identify the combination of genes involved in OCD. There are also neurochemical factors. So different neurochemicals, including serotonin and dopamine and glutamate are also involved in the presence of OCD. There is dysfunction in the systems that involve these neurochemicals. And speaking of systems, the neurocircuitry involved in OCD, there's a particular circuit in the brain that have higher levels of these neurochemicals, actually. So it's not just one or the other, it's a combination of these things where there is systemic dysfunction, essentially. So we know that there is something wrong in terms of how that circuit functions in the brain. And then there's also learning. So we know that there is fear conditioning involved, and I'll explain what that looks like, because it is working on that fear conditioning behaviorally that is really what we do to treat it effectively. But first, let's touch on medications. So to talk a little bit about the medications that are used to treat OCD, the most common class of medications used to treat OCD are called serotonin reuptake inhibitors. And those include drugs like fluoxetine and fluvoxamine, sertraline, paroxetine. That's Prozac and Luvox and Zoloft and Paxil. And then a couple of other drugs. Those are FDA approved for OCD treatment. And then a couple of other drugs, citalopram and escitalopram, are medications that are similar in terms of their how they function. However, they are not officially approved by the FDA to treat OCD, but they are typically used off-label. So we do see them used to treat OCD in the psychiatric world. So SRIs are the most frequently prescribed and most consistently superior to placebos and randomized controlled trials in the treatment of OCD in both kids and adults. They do result in significant symptom reduction for individuals, but it's good to keep in mind that when we talk about what that means, what significant symptom reduction means in terms of psychiatric medication studies, that really means that they demonstrate a 25 to 35% reduction in symptoms as measured by an OCD measure, specifically the Yale-Brown Obsessive-Compulsive scale. So we're looking at a significant reduction in symptoms, but not an elimination of symptoms by any means. Something to consider is with the SRI medications come a black box warning for youth that involves suicidal thoughts. So it's something that we need to keep in mind when we're prescribing SRIs for young people. And there are also side effects of these drugs. And so these are things that people need to consider when they consider pharmacologically treating OCD treatment. Symptoms relapse, unfortunately, upon discontinuation of these medications if they're treated with SRIs alone. And so typically when we see someone treated with medication alone for OCD, we see them on it for the long haul. And unfortunately, although it does help a significant number of people, about 40 to 60% of individuals who are treated with SRIs don't respond to SRIs alone. And so it is not the answer. It is a tool in the toolbox to help individuals with OCD. And there are other medications as well to be aware of that are used to treat OCD. The serotonin norepinephrine reuptake inhibitors, or SNRIs as they're referred to, including clomipramine, which is anafranil, and venlafaxine and duloxetine. These are medications that are all used at times to treat OCD. Clomipramine is one of the original drugs that was used to treat OCD in treatment studies. And venlafaxine and duloxetine, even though they're off-label medications, they are frequently used to treat OCD as well. Studies do suggest that these drugs may be as effective as SRIs. Everyone's body is different and responds differently to these drugs. So typically, first-line treatment medication are SRIs, and if people don't respond to those drugs, then second-line treatment is typically trying an SNRI. Then there's also augmentation. So sometimes people don't get enough benefit, the desired benefit from these medications. And so sometimes prescribers will add other drugs on in combination with an SRI or an SNRI. And that class of medication is referred to as antipsychotics, or sometimes we call them neuroleptics. Those are drugs like aripiprazole, risperidone, quetiapine, olanzapine. These medications are sometimes added on in small quantities and can be helpful to further reduce symptoms. However, as with the other medications, there are side effects that are related to these medications. And so people have to kind of weigh the costs and benefits of these potential treatments. In terms of the psychological treatments for OCD, cognitive behavioral therapy, and a specific kind of cognitive behavioral therapy that we call exposure and response prevention. If we're over 40, we call that ERP. If we are under 40, we call that EXRP. I don't know why that is, but that's something that I have noticed over the years. And that is really considered the gold standard treatment. It is a treatment that is consistently superior to wait lists and placebos in randomized controlled trials. It results in significant symptom reduction and maintenance of gains upon discontinuation. So people tend to maintain their gains once they're done with this treatment. And there are costs as well to this, right? There are no side effects, but there are certainly costs. First, the therapeutic process can be really challenging. It's not easy to do exposure and response prevention work. It is hard work, and people do experience some distress when they do it. It is certainly worth it, but there is definitely a cost because it is difficult work. And it can also be difficult to find an experienced provider who knows how to actually provide this kind of treatment. And so that is also sometimes a barrier to getting good exposure and response prevention treatment for OCD. So how do these treatments stack up? Well, when we look at all of the studies taken together and we analyze that in a meta-analysis, what we learn is that in general, CBT is superior. CBT gets a greater reduction in symptoms than SRIs alone. Combination of CBT and SRIs tend to do better than SRIs alone. So CBT is clearly a really helpful active ingredient. CBT and SRIs are not superior to CBT and placebo. So as we can see, CBT is really the active ingredient in terms of what helps people to decrease their symptoms for the long term. When CBT is added to someone's treatment after discontinuing SRIs, what we see is that people tend to be able to maintain their treatment gains. So whereas on SRIs alone, if you stop your medication, the symptoms will reemerge. If you're doing CBT, then you can maintain your treatment gains. So that's a helpful addition to SRI treatment. Those who don't respond to SRIs do benefit from CBT rather than SRIs alone. So those individuals who take medications don't find it helpful, but tend to stay on it because they don't really know if there's an alternative that will be helpful for them. What we find is that SRIs, non-responders do benefit from CBT. And for those who don't respond to CBT, because it's not a panacea, there are people who don't respond to exposure and response prevention. What we find is those people also don't improve if they discontinue CBT and they're put on SRIs instead. So for whatever reason, people who are treatment refractory and difficult to treat tend to be treatment refractory and difficult to treat, whether or not they are engaged in CBT or whether or not they're treated with medication. So what is exposure and response prevention? So exposure and response prevention is a psychological treatment that is a systematic way of helping individuals to confront that which causes them distress, their obsessions, and refrain from engaging in behaviors that avoid, resist, or reduce the distress, the compulsions, right? The exposure is the confrontation of that which causes them distress, and the response prevention is preventing that learned response, preventing the compulsion from occurring that would typically bring down the stress. So why do we do that? That seems quite difficult to experience. Well, it's all about learning. So our minds are constantly learning. When, for example, we have a small child, we teach that small child that a dog says woof. And we say, what sound does a dog make? And they say woof. And we say, yay, great job. And all is right with the world. And so they learn that a dog says woof, and woof is the sound that a dog makes. And then when they start to learn their letters, we say to them, this is D-O-G. D-O-G spells dog. Dog is spelled D-O-G. And they learn that the word dog is spelled D-O-G, and D-O-G inversely is dog. And then one day, we bring home to the family this adorable little dog. And the child learns that this adorable little fluffy creature is a dog, a D-O-G, and he says woof. So all of these things become connected through learning. And everything is wonderful until it's not. Because one day, you're taking your child out for a walk and you're walking by the neighbor's fence, and the neighbor's dog barrels out of the gate of their fence and starts barking and chasing you and your child. And the child gets very scared and starts to run and starts to cry and is very upset. And so unfortunately, the child learns that this is also a dog, that this dog can be dangerous, that this dog can be scary, and that the dog can do more than just say woof. And so the child learns that dogs can be behind fences and that sometimes they might be angry and they might be aggressive and they might be scary. And so this becomes associated. And so, for example, you might be out walking one day in a completely different neighborhood, and you might walk by a fence and the child might start to cry because they remember the scary dog who barked and ran out of the fence and started to chase. And maybe even the child might get nervous when its cute little fluffy dog at home starts to growl because it's upset that it wants to maybe go outside when you're not ready to take it outside. And they might get upset and start to cry, even though that's your cute little fluffy dog. And that little fluffy dog has never done anything aggressive to the child. And so this is how fear conditioning happens. All of these things become associated because we are creatures of learning. Now, the problem is that in OCD, not only do our minds make these kinds of connections, but in OCD, our minds make really arbitrary connections, different kinds of arbitrary associations, more so than in individuals without OCD. And so what we see, for example, is that in OCD, as thoughts and emotions and these experiences build bigger and bigger associative fear networks. So for example, you're sitting at dinner with your spouse and you're having a lovely cut of steak and some vegetables, and you're cutting that steak and you have the intrusive thought, I could lose control and kill my partner. And this is really upsetting. And your mind associates sitting down to dinner with the idea of losing control and killing your partner. And so you become very distressed and very upset. And your mind associates sitting down to dinner with a knife and a fork in hand with the idea that you could lose control and kill your partner. And then the next day, you're sitting down to a movie in the evening with your partner, and you see a scene in the movie where the individuals are sitting down to eat dinner in a restaurant, and it reminds you of the idea that you could lose control and kill your partner because it reminds you of sitting down to dinner the other night when you had this thought. And so, as you can see, the fear network is growing. And then the next day, you're giving a presentation at work and you write the word skills up on the whiteboard. And you notice as you're writing the word that the word skills has the word kills in it. And kills reminds you of the intrusive thought that you could lose control and kill your partner, and feeling really scared and out of control. And so all of these things become associated with one another, things that are directly related, things that are loosely related. And this is how that fear network grows. With each activation of this fear network, you then respond by doing something, a compulsion or an avoidance behavior, to try to move away from or get rid of these frightening feelings, because it's really terrifying and really unwanted and really aversive. The problem is that we are creatures of addition, not subtraction. So we can't undo learning. We can't make these learned experiences disappear. So what happens is that when we try to avoid or neutralize them, they are going to inevitably come back up, because these fear networks are going to get activated out in life, when we're out to dinner, when we're in the grocery store, when we're doing just about anything could be loosely associated with this thought and this experience. So we try to push away these experiences, but they come back up. And the more and more we respond to them by engaging in some kind of experiential avoidance behavior, trying to push them away or engage in a compulsion, the more we learn to respond that way when it comes back up. And so the fear network grows and grows. So the good news is that this is why exposure and response prevention works. We have a therapy that allows us to facilitate new learning. Now, we can erase these experiences, but what we can do is facilitate new learning experiences that have a different outcome, and it feels different. So those new learning experiences or exposures in exposure therapy, the main goal is to experience that association in a way in which the feared outcome is disconfirmed, right? You sit down to dinner with your spouse and you're using a steak knife, and maybe you're having the thought that you could potentially lose control and kill your spouse, and you don't do it. So you learn that that's really not likely to happen. And you also learn, the second goal, that you can tolerate that distress. It's unpleasant, you don't like it, but you learn that you can take it. You can tolerate anxiety, and that anxiety is not harmful, but it is unpleasant and uncomfortable. And that new learning over time becomes stronger with repetition. And that's why we engage in exposures in a number of times, because we want people to get really good at experiencing those situations and learn that these are really not dangerous situations and that they can tolerate the distress associated with it. And paradoxically, what sometimes happens is something called habituation, where we essentially no longer really respond to it with that anxious response anymore. Doesn't seem like a big deal. Lots of people habituate when they engage in exposure and response prevention therapy. In other words, what we want people to do is we want people to do the things that cause them distress so that it becomes easier to do the things that cause them distress. And that's really the goal for ERP. And I promise it does not look like this. It never looks like this. This psychologist is saying, as he throws lightning bolts at the patient, if you'll just relax and trust me on this, Mrs. Snyder, in 45 minutes, your fear of thunderstorms will be completely gone. It doesn't work like that. It's a collaborative, gradual therapy. So the way that we do this is, first, we have to set a really good foundation for successful treatment. And that begins with a really good therapeutic alliance, right? This is a collaborative effort. We would never do anything with a patient in terms of exposure that a patient wasn't ready for. These are things that we come up with together and we do together. So we have to make sure that we have a really good working relationship. And we help patients to understand the workability of their current patterns. By engaging in these avoidance behaviors and engaging in these compulsions, it's taking them away from the life that they want to have. There are very high costs of maintaining these behaviors. It's really impairing their functioning. And so we help people to evaluate the costs of maintaining the pattern in this way. And then we help people to identify their values. What's important to you? What are the characteristics you want to bring to the things that you do here? Why is it? What's going to motivate you to engage in this treatment? Because there are probably lots of other things that are important to you in your life. And I'm sure OCD is not one of them. So we really want to orient individuals toward who and what's important to them in their lives. And then we engage in ERP in such a way that emphasizes willingness to exercise curiosity in engaging in these things. We don't want people white knuckling it. We want people to approach these exposures with curiosity and to become a skilled observer of their own inner experience in the presence of discomfort. What happens when you sit down to dinner with a knife and fork? Do you feel uncomfortable? Do you notice thoughts? Do you notice emotions? Do you notice physiological sensations? What if you stay there and you keep using the knife and the fork sitting next to your loved one? What's that like? To be a curious observer as they engage in the exposure, to set the intention of slowing down, to make comfort with one's discomfort in the moment, to step back and observe what your mind is doing during it, the narrative that it's trying to sell you, examine the experience fully with all 5 senses in the moment. This is what leads to people improving. So what in the world does that look like, and how do we do that? Well, the process begins by collaboratively identifying the obsessions, the compulsions, and other things that people do to try to maintain safety and feeling self-comfort, and then identifying the feared outcomes if there are. So for example, an obsession might look like, I'm afraid that I may start a fire if I'm not careful enough. And the feared outcome would then be that the house would catch on fire, that their loved ones would die, that they would lose all of their belongings. And that causes them a great deal of distress. So SUDS is a subjective units of distress. On a scale of 0 to 10, 0 being no distress at all, 10 being the worst distress I've ever felt. How does that feel? And this might be, let's say, a 9 for someone. And then what do you do when you're feeling that way and you're having this mental experience? What do you do to try to reduce the distress? What are the compulsions and safety behaviors? So someone, for example, may check the stove dials to make sure that the stove is off every night or after cooking or throughout the day. They might check the electrical outlets and plugs to make sure that everything looks okay, or to even make sure that everything is unplugged after use. The obsession of blasphemy or offending God in some way, that scrupulosity, religiosity sort of obsession. They may fear that if they don't do things properly and follow their religious doctrine to the law, that they're going to go to hell. And that might cause a great deal of distress, like an 8. And so they might engage in compulsions, for example, like praying. An obsession like spreading disease might be associated with the fear that ultimately, if they unintentionally spread disease to a loved one, that their loved one will die. That causes a significant amount of distress. And then they may do things like washing and avoiding touching different surfaces in the attempt to try to avoid that feared outcome and reduce their distress. And so we want to really create a really detailed chart similar to this of what their OCD looks like. And then the way that we carry out the plan is we want to make sure to maximize treatment success. This is called the inhibitory learning model. We want to make sure that there's an emphasis on repetition. We want to do these exposures repeatedly so that they can have multiple experiences of learning, new experiences, and expectancy violation, right? So we want them to learn that what they thought might happen doesn't happen. So we need them to do this a number of times so that they can learn, even though I didn't do this compulsion to bring down my distress, my fear did not actually come true. This didn't pan out the way that I thought it might. And so we need that learning to happen. So we do this multiple times. We do exposures or exposure challenges involving multiple fear cues, because that also maximizes treatment success. So what I mean by that is we want people to involve external cues like using a knife. We want people to engage their mind, cognitive cues like intentionally having the thought I might lose control and kill my partner. We want them to identify their emotional experience, that they're anxious, for example, and we want them to acknowledge the physiological symptoms as well. Their heart is racing, perhaps they're sweating, they're having that fight or flight nervous system activation response. And so we want to make sure that we try to involve all of these different cues, because the more we can involve in the exposure, the quicker they'll get better. And also occasional reinforced extinction. Every once in a while, something bad does happen. Not a really terrible thing, but a little terrible thing. So for example, we might be doing contamination exposures one week, and the next week, maybe the individual has a cold. And they might think, I bet I got this cold because we did those contamination exposures and I went around touching all the doorknobs in the office building. And whereas that might be, it's also okay. We want them to see that even if a feared outcome does happen, they're okay, that this is something that they can tolerate and get through. So it is okay to have an undesirable outcome as the result of an exposure, or to tell yourself that these things were related. We want to make sure that we label affect. In other words, we want people to name how they're feeling. This is making me feel really anxious now, or I'm feeling really disgusted by touching this dirty surface. That helps. We want people to use exposure variability. In other words, I want people to do things that are easy and also things that are hard and things that are somewhere in between. Now, I want them to mix it up as much as possible. When we vary the level of distress and exposures, people tend to get more mileage out of ERP treatment. We want to make sure that they're willing to do this. We want to make sure that we vary the situations and the context in which we do these exposures. So if we're doing exposures to eating with knives, for example, we might do that in the house at breakfast. We might do that at dinner in a restaurant. We might do that, somewhere else. We want to vary it as much as possible. And we want to remove any kind of safety signal or safety behaviors that is carried out and associated with the symptoms as well. So for example, if someone has this thought that they may potentially lose control and hit a child. We want to make sure that one of the things, if they're engaging in safety behavior of always having another person present in the room with a child, we want to make sure that we remove that safety behavior so that they can learn that they don't need that in order to keep safe. So what this might look like. A 35-year-old female with the thought, what if I lose control and kill my husband, engages in compulsions in response to that fear of reassurance seeking from others, keeping sharp items out of her reach so that she can't access them, avoiding using sharp knives or scissors in the home, avoiding watching the news because she might see violence on the news, which might trigger the obsession, avoiding watching violence on TV or movies for the same reason, mental checking of her own values. Would I do this? Would I not do this? This is not something that I would engage in. Checking one's love for their partner. Do I really love this person? I wouldn't do this because I love this person. Engaging in pleasant mental images as a substitute for the unpleasant obsession in the mind, and mental reassurance, telling oneself that this is not the case and that everything is okay. So the way that this might look in terms of developing an exposure menu for this person is we use the information that we've learned to construct a menu of exposure challenges, and one by one in a collaborative way, we want them to engage in this exposure and engage in the response prevention plan. So for example, we might start off with the task of writing a story or a narrative about the person killing a loved one. And we might have them write it and then read it out loud. We might have them record it on their phone and listen to it over and over. We want them to come into contact with that narrative. We want them to perhaps hold a sharp knife to the wrist of a loved one while recalling a time when they felt angry or upset with them. Another thing we might do is use a sharp knife while eating meals with a loved one, while making statements of uncertainty like, I don't know, I could lose control and stab them. I don't know, I could, maybe I will, maybe I won't. And as they're experiencing their discomfort, we want to make sure that they abide by those response prevention guidelines that we set up to ensure that they're not going to carry out any compulsive behaviors to reduce their distress or to reduce the likelihood of the feared outcome that they perceive. So what we might do for this person is to reduce or eliminate reassurance seeking, to make sure that they take the knives and the scissors back out to restore access to that, so they're accessible again, to make sure that they're not avoiding using sharp knives or scissors, to make sure that they're not value checking mentally, to eliminate internal reassurance provision if they're saying phrases, for example, that tells themselves that they're not going to do this and that everything is okay. And if they do engage in mental rituals, because it can be very difficult to prevent a mental ritual, we want them to spoil any kind of corrective mental ritual. Like if they have a positive image that they imagine as a way to make themselves feel better, we want them to spoil that image in some way. So if they imagine sitting in their favorite vacation spot with their spouse as a way to try to make themselves feel better, we want them to imagine perhaps stabbing their spouse in that place to spoil that means of trying to make themselves feel better. Same thing with mental reassurance. If someone engages in mental reassurance, telling themselves that everything is okay, we want to make sure that they spoil that if that happens. To say statements of uncertainty like, well, I have the ability to kill my spouse. Maybe I will, maybe I won't. I guess I don't know for sure. So we want to slowly and systematically engage in one at a time this plan and see that their distress tolerance builds and their symptoms decrease. And just a word about family accommodation. It's really important to address the involvement of family in individuals that have OCD and their OCD cycle, because anxiety is really provocative and it can really lure family members in to helping OCD. And what I mean by helping OCD is to help OCD and not the person. Because what happens is if someone is really distressed, if a loved one is really distressed, it's going to be your natural inclination to help them feel better, right? To let them know everything is okay and that they're safe. And we might even do things to help them feel better. So if they're not comfortable opening a door, for example, we might open the door for them because they're upset and they're distressed, and we don't want them to feel upset or distressed. And so what happens is that there is certainly short-term relief when we engage in those kinds of behaviors as family members, right? It helps our loved ones feel better. And it also helps to maintain the family functioning, right? Because if a person is avoidant of door handles, for example, and they insist that the relative open doors, well, if the relative says, I'm sorry, I can't do that, I'm not going to help OCD, well, that could lead to a problem, right? That could really lead to a tantrum if it's a kid, or simply being frozen and upset in one's OCD distress. And so what happens is individuals, family members carry out these behaviors to help OCD. But there is a long-term cost, which is just as individual compulsions reinforce the cycle of anxiety and learned fear conditioning, so does these behaviors also do when a family engages in behaviors that reduce the individual's anxiety as well, or provides them with reassurance. And so that also reinforces fear conditioning. And so what we need to do in treatment, typically, if there is family accommodation, for example, in the home, is we need to make sure that we teach family members effective emotional support skills. So we want to teach them how to talk to the individual when they're upset, to not reassure them that everything is okay, but to reassure them, for example, that that they understand that the person is experiencing a lot of anxiety, and that's really uncomfortable, but that they know that they can handle that anxiety. That's really what we want to get across to them, that they can tolerate that distress, and to help them learn ways to effectively respond. Like, I love you, and so I really can't do this for OCD because I want you to get better. I don't want OCD to tighten its grip on you. So we teach them different ways to respond so that they can extract themselves from the OCD cycle. All right, that was a lot in terms of a little overview of OCD and its phenomenology and the treatment approaches. I'm happy to answer any questions anyone has. Have a discussion.
There's a question. It's actually from me. So we know COVID increased rates of anxiety and depression. Have we seen any increase in OCD occurrences or behaviors or anything like that?
Yeah, that's a great question. Yes and no. So individuals who had contamination OCD struggled more with contamination OCD. So if they were already worried about germs and illness, they were extra worried about germs and illness, and their symptoms did get worse. Other kinds of OCD, not necessarily, but we definitely saw contamination OCD get worse. And the interesting thing as a therapist that we needed to do is we needed to adjust the way that we engage in exposures during COVID, because we were doing all sorts of things that pre-pandemic seemed okay, touching toilets and licking our hands and eating off the floor and touching random surfaces and rubbing our faces and touching dumpsters. for contamination, for example. But, we really kind of had to reevaluate what the new guideline is for safety. And so as an OCD therapist, I couldn't believe, in March 2020, before we went home, I had a bottle of Purell sitting on my desk, which, oh my gosh, that's not an OCD therapist's favorite item at all. I never thought I would have a bottle of Purell in my office, but we were really kind of discussing, how to adjust our response prevention guidelines and our exposure so that they were actually safe, as opposed to just a perceived risk. So it's been an interesting journey over the last couple of years.
Thank you. There's another question. Is it common for people to have multiple obsessions? If so, does each obsession have to be treated individually?
Yes. So most people do have multiple obsessions and multiple compulsions, and we typically treat them individually, one at a time, like little islands. We want to conquer each island first. So if someone has contamination OCD and also fear of harm, we want to do one first, create an exposure menu related to that, do all that work until that's better and no longer really problematic, and then we'll move on to the fear of harm.
There's another one. Are repetitive dreams related to OCD?
I've never read anything about dreams being related. Dreams are interesting. We really don't know a lot about why we dream what we dream. What we know about dreams is that it seems to be the brain's way of resting and consolidating our daytime experiences in terms of our memory. So it's interesting that when we have particularly stressful days, the content of our dreams tend to be really high stress. But what we usually tell people is that content is much less important than the emotion in the dream. So if you had a really stressful day, for example, and you were upset about something other, you might be upset in the same way in the dream, but the content might be entirely different. It's just your brain's way of trying to make sense of what happens during the day, consolidate those experiences into memory.
There's another one. Do we know what causes specific obsessions to develop, such as like a loved one dying of a disease or something like that? Or are some of them just kind of random coincidence?
OCD loves to grab onto what's important to people. If it wasn't important to people, it wouldn't bother them. So unfortunately, OCD hits people where it hurts. So if, they're really, if they are, losing a loved one, if a loved one's really sick and dying, they may grab onto, fear of dying, fear of illness. It's funny how that works, but OCD grabs at the things that are our highest vulnerabilities. The other thing that we see is that OCD grabs onto what is important to people at different developmental stages. So, for example, in kids who are preteens, for example, we'll see concern for saying things offensive or cursing unintentionally, unknowingly, getting in trouble. We might see things like obsession with thoughts of suicide or smoking or doing drugs, things that at that time of life, people are told are really not acceptable things to be thinking about or doing, that we don't necessarily see later on. Like I don't think I've ever seen an adult who has an obsession with smoking, but I definitely have seen some kids who have this obsession with smoking where they're upset to even think about smoking or see someone smoking because it seems like something that is really taboo to them, whereas adults not so much. OCD can manifest in so many different ways, but it's usually something that is of some kind of significance to the person.
Thank you.
Mm-hmm.
Any other questions on anyone? All right, well, we're getting a thank you and excellent presentation from some of our attendees. So I'd also like to thank you on behalf of NAMI Mercer. This was absolutely wonderful. Oh, I'm sorry, there's one more. How do you assist OCD sufferers to do the hard work of ERP?
Having a really good working relationship so that the individual trusts us is really essential. And helping people to sit with their internal discomfort. Slowly, we usually start off slowly, gradually, and then move to, variable. We really try to pay attention to willingness. How willing are you? What is something little we can start off with that you're willing to do that will make you feel a little bit uncomfortable? So that they can have a mastery experience, so that they can say, hey, I didn't think I could do this, but I did it. Okay, what's next? So we build upon the experiences that we create.
All right, it looks like there's no other questions coming through. We do have one more comment though. Thank you so much. I have a better understanding of OCD now. So
thank you so much. I appreciate the opportunity to speak to everyone today. And I hope everyone has a great rest of the month conference activities.
Thank you so much. Everyone really enjoyed it. So this will be recorded and available at a later date. And remember to stay on for the survey, guys. Thank you so much.